Hi everyone, I am Saniya and in this video I want to talk to you about some of the pros and cons of decision curve analysis, DCA. So what are some of the strengths and what are some of the weaknesses of this approach? But I think it has a lot of strengths, especially for clinical decision making, for evaluating and utilizing machine learning predictive models that have scope, especially for healthcare applications, like deciding to send a patient for treatment or not. And how do you evaluate those? So I want to talk about some of the pros and cons of decision curve analysis in this video. So firstly, because I'm impatient, I want to talk about the pros of decision curve analysis. What are some of the strengths of DCA? Why should we use it? Why is it beneficial? I'm a huge fan of DCA. So when it comes to medical decision making and trying to interpret predictive models, you can do traditional statistical analysis, simple mathematics. You don't need additional data. This is often like, AUC, area under the curve, area under the ROC curve, accuracy, number of errors, number of accurate predictions out of the total predictions, for instance. So it's just a simple way to gauge how accurate are your predictions. You look at the accuracy, number of true positive and true negative divided by all the total number of predictions, get your accuracy or get your area under the curve, or F1 score. So there are a variety of metrics, and you don't need any additional data. You can have binary, continuous data. It's just that you just view how well you are able to correctly predict whether someone has coronary heart disease or whether they don't. That's all you're trying to predict and assess. So for clinical value, often it doesn't really distinguish the types of mistakes because, wrongly predicting that someone has coronary heart disease, the effects of that mistake of them going for unnecessary treatment, that's a false positive because you falsely believe that they're positive for coronary heart disease. And that type of error could be very different in terms of its results than a false negative. And a false negative is that you are wrongly predicting that they do not, the patient does not have coronary heart disease, but they actually do. So in that case, they are missing out on potential life-saving treatment, and it could progress to a stage where maybe it's too late to save them, or they've already lost a lot of potential life that could have been saved had it been detected earlier. So maybe getting them wrongly treated for coronary heart disease could lead to something else down the line. So there are a lot of outcomes from false positive and false negative mistakes, which may or may not be equal. But if we're just looking at, if we're just looking here at like false negative, false positive, then this is just this traditional approach just sort of weighs them equally. Hey, let's cut down on a false negative and false positive errors. Let's try to get as many accurate predictions as we can. But they don't kind of weigh them that differently, most traditional statistical analysis. And even still, you don't need additional data. You just need to know how well your predictive model did in terms of, you just need to know the actual outcomes and just how well it did. There's no way for you to assess the clinical value as much because you really don't know the true cost of a false negative and a false positive. But if you want to integrate that information, if you want to actually figure out how much does a false negative, how much does saying that somebody doesn't have CHD when they actually do, how much does it actually cost, that kind of mistake in terms of life years on average, or but how much does it cost if you falsely say that somebody who doesn't have CHD actually does? If you have a false positive, like what is the cost of unnecessary treatment, unnecessary stress? What are the costs? So the math can be complex, and often you might need to ask patients for their preferences. What are the typical costs? How effective is it? You might need to talk to clinicians to figure out, okay, well, if they go for this treatment, what are the outcomes if they don't have it? Like, can it lead to some other conditions? Can it deteriorate their quality of life? Does it cost a lot of money? What is it? So you need to get that data as well on what patients prefer, how much do they think like average life years lost if it's not detected properly. So you need a lot of extra data on that, which can be cumbersome and sometimes really hard to get. So, you can definitely assess the clinical value, but you do need to figure out how do you collect that kind of data? Where do you go looking for it? And if you're not a specialist, how do you figure out what that is? So it's challenging to incorporate clinical value of a model in terms of the impact of the mistakes it's making, because different predictive models may make different types of mistakes. One may make more false positives than the other. And one could be better than the other based on what you value. So you really need to take in the costs as well, but it's hard to procure that, and you do need additional information. So in response decision curve analysis, it's simple math, and it doesn't really need for you to get information on patient preferences, cost, or effectiveness. It just uses an estimate. So it sort of leaves it to you, in your view, in your vision. It does all the calculations using the same kind of metrics that I use traditional statistical analysis, but it's the way that it reframes it in a way where it sort of gives the power to you on which predictive model you want to choose using your probability threshold based on your risk preferences. That in some ways in your mind you have an idea of how much of how bad each mistake is, a false negative and a false positive. You have some idea, which is why if you choose to go for CHD treatment, if you have a predicted probability, let's say of 10% of having it, then for you, the mistakes of not getting treated for it when you actually have it, it's 9 times worse than, wrongly getting treated for it when you don't have it. So it's sort of like the threshold that you're choosing. If it's 10%, you're super scared that there's a 10% chance I could have it and my life is going to be really deteriorated if I don't get treated for it on time, and I have it. I'm ready to take the 90% chance that I don't have it. I want to go for treatment even if it's 10% chance. But for someone else, maybe they would go if they have a 15% chance or 20% chance of having CHD. And in some ways, in their mind, they've done that cost-benefit analysis, which is why they've chosen that threshold. So it sort of leaves it to you based on the probability threshold that you have. It sort of tells how badly you view and weigh these mistakes. Because in your mind, like if you have cancer and you don't go for treatment, unless you have a certain probability threshold, let's say of 35%, it might be higher than it is for someone else who goes for treatment if they have a 25% chance of cancer. So maybe you don't view the false false positives as being not as bad as false negatives, for instance. It really depends on your probability threshold. And they can use as clinical value. So basically a probability threshold basically is telling how do you weigh the mistakes of false negatives versus false positive. The higher the probability threshold is, that means that you're more scared of a false positive than a false negative. You want to be really sure that you don't wrongly say that someone is positive when they're not. So the higher the probability threshold is, the more weight you're giving to your false positive. The lower it is, the more weight you are kind of giving to a false negative. That, hey, I really don't want to make false negatives. I really don't want to say that somebody doesn't have a CHD when they do. I'd rather just be safe. So it's all that balancing act, and that sort of tells you how bad the different mistakes could possibly be in your mind. And just for a very quick review, and I would have other videos on this, but the area under the receiver operator characteristic, the ROC curve, the AUC, is what AUC basically represents. This is a random chance, like a coin flip. and we want higher area under the curve here. So it's looking at the false positive rate and the true positive rate. So false positive is like when you're in clinical decision making, when you predict someone has a condition, but they actually do not have it. And true positive is you predict that someone has a condition like the disease and they actually have it. And yes, this is false positive and true positive rate. Randomness, the area under random is 50% from a random classifier. And then as you see, the green is getting better more than the random. The orange is even better, and blue is better, and a perfect this blue is better because the corresponding like area under this is going to be higher than under the other orange and green. But the perfect one here, the perfect classifier is essentially this. So essentially it has 0 false positive and all of them true positive. That would be ideal, to have no false positives and to have 100% true positives. That would be great. So out of all the positives, like how many are correct? So basically the idea is that the area under the curve is one of the approaches to evaluate predictive models. We can look at the accuracy, the number of correct predictions, true positives and true negatives divided by false positives plus false negatives plus true positives plus true negatives, the correct predictions over all the predictions. Or we could use area under the curve, but these don't really give us much information as much about the clinical consequences of false positives, of wrongly predicting someone has the disease when they don't have it, versus false negative, like not predicting someone has the disease when they actually do have it. So they don't give us that kind of information, which is why decision curve analysis is super beneficial, because it can help account for the fact that, hey, we did not predict that you had cancer on time, and now it's advanced to a severe stage and you've lost out on years of life, which is very sad. So that's a consequence of a false negative, a falsely saying you don't have the disease, of the predictive model making that prediction. But a false positive is that we falsely, a model falsely predicted that you have the disease and we treated you for it, but instead you actually did not have it. And because of that, you're suffering from the side effects of the treatment, the money, the stress, all of that. All of the stress, money, inconveniences, side effects, other risks from that treatment, from having a false positive. So these don't seem to incorporate that as well as DCA can, which is why I'm a huge fan of DCA, because it helps with clinical consequences and medical decision making and evaluation of predictive models. So decision curve analysis, DCA, it has some key benefits. So traditional metrics, they do not give us the clinical value of a predictive model as much. So we can look at like accuracy measures, like sensitivity, specificity, area under the curve, that's AUC, but they don't share as much about the clinical value of a model. Typically though, a model with higher AUC is typically likely to be more valuable than a model with lower AUC. So the higher the area under the curve, you would expect that model to typically be better than a model that has a lower area under the curve. Nonetheless, though, it is still possible that if you have a model with a higher AUC, it could still be inferior and have worse outcomes overall than models with lower area under the curve. So that is that having a high area under the curve for a model is not the sole metric that you should be looking at for determining if a model is strong, especially for clinical applications. So again, it's possible that even if one model has a higher AUC area under the curve than the other, it may not be performing as well overall when you consider everything, especially for clinical decision making. So there's a lot of subjectivity that goes on. But and if you had to evaluate using traditional metrics, you might need more information on the cost or effectiveness of the treatment, or how patients value different health states. That's also known as health state utilities. Like, how do I value, getting cancer and getting treated for it, getting treated for cancer versus when I don't have it, versus not getting treated for cancer when I do have it. How do I value the different outcomes, or successfully getting treated for cancer when I have it, or avoiding treatment for cancer when I don't have it? Like, how do I value these four different outcomes that we can have? And again, these are the four outcomes that traditional predictive models tend to return to us. We can have true negative, true positive, false negative, false positive. Of course, they're really based on our actual outcomes. So if we actually are positive or actually are negative for the disease. But in general, DCA, we do not need extra information on how much those would actually cost us. Like, what is the cost of cancer treatment, or what's the cost of missing out on extra years of life because the cancer went to an advanced stage. So you don't need that information for DCA, but you would need it for, like, if you're using area under the curve, or other approaches, because they would need that health information, like the health state utilities, like how much do you value each of those. But instead, decision curve analysis can be directly applied to a model validation data set, and the way that it figures out how you value different health states is actually measured by the probability threshold that sort of intrinsically tells how much each outcome is worth to you. So, decision curve analysis can be applied to analyze various predictive models and tests. So, we can look at multivariable prediction models, and the outputs of those models typically are the probability of an event. So, for example, what is the predicted probability of us having cancer? Or we can also look at standard diagnostic tests, and the output of these tests produces simple binary result like, do you have cancer or not? So, decision curve analysis can be applied to these various predictive models and tests, so it has a wide scope of application, which is key. Like here, for instance, we can see the decision curves for a cancer model, for the resection of a tumor for prostate cancer, for instance, and we can see the optimal threshold in terms of when the predictive model does the best according to your preferences as well. Resection if the prediction is greater than the threshold. So basically, if the predicted probability for a patient having the resection of the tumor is greater than or equal to the threshold, then you go with resection. So this just shows how, again, decision curves look and how they can be applied to probabilities or standard diagnostic tests. And this is, again, a DCA example, and I have other videos talking more about DCA and the concepts and other applications. So please do see those in my playlist that is in my bio. And please don't forget to subscribe as well. There are several key advantages of decision curve analysis, and I want to talk about two of the key ones, for instance, that were also mentioned in the original paper by Dr. Vickers. And so of these two ones, piecing out, one is that decision curve analysis, DCA, can help us quantify the benefit of using a prediction model in simple but clinically meaningful terms. So we can ask and answer, what is the value of a prognostic prediction model in terms of like clinical decision making? Like how much can it help us if we were to use it, to come up with decisions to send a patient for a treatment, if we predict them as being positive from our predictive model, and we send that patient, he, she, or they, we send that patient for treatment for the condition or disease. How much can this predictive model help us with this decision? What is the net benefit? Net benefit overall on the treated and untreated, or net benefit on the untreated, or what we popularly use is the net benefit on the treated people, the treated patients. What is that net benefit? So sending the patient for treatment is usually net benefit on the treated. And that's all the same, as I'll show you in other videos, that whatever net benefit you use, it's going to be the same interpretation, but decision curve analysis just helps us figure out what's that net benefit for those individuals in clinical settings especially. And that's one way, we can better analyze the positive effects. DCA can have a second advantage, which is that it can be used to help compare several different predictive models. So the way that we can go in is we can have risk preferences, by our respective probability threshold. We have a range of probability threshold values. For instance, I'll go for treatment if I have a predicted probability of having the disease that is at least 28%, for instance. Then which models tend to do the best for 28% or higher? or in a certain range of intervals between 0 and 1, which predictive model tends to have the highest net benefit values, then it tends to be optimal. So I'm comparing my predictive models against each other and against the extremes of let's treat all patients or let's treat no patients. Those are the two extremes that we're trying to compare those against and see what is the net benefit, what is the impact of these predictive models against just treating everybody or treating nobody, which ones tend to be the most optimal for many of the probability thresholds, or which ones are optimal for our probability threshold. So based on that, we can then better select predictive models that we want to use and justify why they are useful. So these are the two main advantages of decision curve analysis. So one, again, it helps us quantify the benefit of the predictive models in clinical decision making, especially where the costs of the mistakes, false positive and false negative, they can have very different impacts. And you may have your preferences for which one is better or worse based on your circumstances, your philosophy, your belief system, and also from medical side effects. So this can help you figure out, what is the benefit of a predictive model in terms of the net benefit, and you can also better determine which predictive model or models will be giving you the optimal results based on your preferences. So one way to say this is that this is more like model justification, like why is it useful? And the second one is more like model evaluation, kind of choosing that predictive model that gives you the best results overall. So those are the two main advantages. So model justification, why is it beneficial? What can we see is the impact of using this model in clinical settings? And the second one is, how can we choose a predictive model? Or why is this predictive model better than the other? So it's used for evaluation and comparing different predictive models. So those are the two main benefits up front. And for this clinically meaningful evaluation, you don't really need more information just besides the probability threshold that is subjective. You don't need to go out and collect all this additional information on the costs and losses of treatments. Now, a pro of DCA is that it's a newer method for evaluating predictive models, and it shows when a prediction model is of value. Unlike other statistical evaluation methods, it doesn't need extra data on profit or loss. It doesn't need more information like life years, suffering, loss, profits, utilities, etc. The only information that it needs is the relative ratio of loss to profit, which is measured by the probability threshold. And it indicates a likely range of clinicians' or patients' risk and benefit preferences directly through the probability threshold. So there are many different clinical uses for decision curve analysis. So to begin with, the clinician can choose a prediction model that gives the highest net benefit at a certain probability threshold or an ideal interval of probability threshold value. So if you have a set of probability thresholds that you believe in, you can choose a prediction model that gives you the highest net benefit. So you can kind of work backwards with that and say, okay, it seems like this predictive model gives me more flexibility for more predictive models. Or you could work backwards, and that's another way you could go about it. So either you could have a prediction model in mind based on the one that gives you the highest net benefit across a wide range of thresholds, and then choose that, saying that this one gives me a higher net benefit for a lot of the models. Or you could just choose one based on an ideal probability threshold that you already have to begin with. Like, let's say that your threshold, is already like 20% or 30%, then just choose the predictive model that has that. Choose the predictive model that already has that net benefit that's the highest for your predicted probability threshold. So you can use it either ways. Either just look at the decision curve, see which one is optimal for many different probability thresholds and choose that one. Or if you already have a probability threshold in mind, just use that and see which model gives you the highest net benefit. And it's subjective because the optimal model you'll come up with might really differ based on your ideal probability threshold or range of thresholds. All right, I have to be fair, so I have to also concede and talk about some of the cons and weaknesses of DCA. So that's what I will do now, just to be fair and to be a harsh critic of a methodology that I like. I'm also going to tell you the cons of DCA and why it's important to be cautious as well when you're applying this methodology. As is the case for applying any methodology in general, you should always be cautious. Also, that's me many years ago as a little grumpy little pipsqueak with my aunt. So that's describing my mood, talking about the weaknesses of DCA. Pretty grumpy. Now, there's some cons of DCA. One of them being that you don't really have any real values or information on loss and profit. So we're only using relative things and not absolute things. So it simplifies things, but it also makes interpretation harder. So it's a bit tough to interpret the value of net benefit and to compare the differences in net benefits between two or more models. So there's no main method for correcting decision curve analysis for overfit, and it may not be effective or as effective for data sets where the outcome Y is not very binary. So basically, sorry, what I meant is that DCA, decision curve analysis, may not be that effective for data sets where the outcome Y is not known. So if you look here, yeah, that's me grumpy. You can see that the hospital bills, sometimes they can be quite atrocious and it's like an emergency. Oh my gosh, what is the bill? You can get like a lot of, the bill could be very surprising. And the thing is that DCA, what makes it simpler and easy to use and has clinical interpretability, can also be a weakness because it's using relative values and not absolute terms. Like, like if you go for unnecessary treatment and you have hospital bills that you didn't need to have, that's also like something that could be a lot. It's shocking to these poor people here. But if you miss out on treatment that you needed, the cancer could also progress to a pretty bad stage. And how do you quantify that, right? So it simplifies things, but it also makes interpretation a bit harder from decision curve analysis. And we don't really know how to correct if it's overfit, which is another risk as well. Like if we choose an optimal model using DCA, what if we're overfitting a lot? So all in all, I hope that this video on the pros, the strengths, and the cons, the weaknesses of decision curve analysis, DCA, has been helpful and informative. And if it is, then please like my video and subscribe. Otherwise, in any case, please reach out with any questions and concerns that you have. I use decision curve analysis a lot. DCA, I think it's a very helpful clinical tool that to be used especially for utilizing predictive models or even for determining which predictive models to use. But I feel better that I've also addressed some of the weaknesses in this approach so that you can have and use DCA with a balanced and overall better mindset when you're using it, knowing the trade-offs about using it and the weaknesses. But it does give a lot of strengths. In case you were wondering, that's my view. I think it's a very strong approach, and not too many people know about it, but it's very helpful. So I just hope that this helped you guys. And again, I'm Saniya, and I'm very, very happy to help. So I hope you guys have a great day.